Say, show me your thumb at the 5-second mark. All right, so this is the technique that I used. I elevated that first rib and with my index and middle finger, and then I pushed on the shoulder blade on the acromion obliquely at a 45-degree angle. And you felt like there was a stretch happening? Mm-hmm. Okay, alrighty. I actually felt the shoulder blade shift a little bit. And now you have spring mobility.
Wonderful.
Okay, so let's have you stand up. And then I want you to tell me how you feel and then show us those movements again.
The pain is gone.
Nice,
Mm-hmm.
nice,
Yeah.
Beautiful, beautiful. Alrighty, well you know how to keep that motion. That's my model of treatment, where in one visit I do the treatment once and once only, and then I teach the patient how to keep that. It's a really bad business model.
Well, I appreciate it.
So let's film the skeleton here. So the head would be here, the person would be on their stomach. And so this is the cervical spine, and then this is thoracic, because the first thoracic joins that first rib. And here you can see that bump, that tubercle, that is taller than the spinous process. You know, it's a little challenging, but in that area, when this pulls out, this definitely becomes more prominent. Mm-hmm. Okay. And I'm going to test rotation of this vertebrae, left and right, and I'll test it with your face in neutral and then in flexion and then in extension, just to make sure there's no restriction of left and right spring mobility of that first thoracic vertebrae. Okay? Lots of people treat the first rib pushing it down and stretching the scalenes, and that's helpful for the scalene muscles, but it will not correct a medial or a lateral rotation fixation of the rib. And when you turn your neck all the way to the left, this rib should come, it should come lateral a little bit, and the opposite is when you go the other way. And I think what happened was you had a passive force just exceed your normal range a little bit, and for some reason the neck rotated back, but the rib stayed at the end of its normal range of motion. So I don't use terms like the rib is out. I don't use terms like subluxation. I use terms like hypomobile, stuck at end range, you know, of its normal movement. Mm-hmm. If it was dislocated, you wouldn't be here. You know, you really wouldn't. So then when you lay supine, then we pinch the thickest part of that trap muscle, and that puts us right here. And then with my index finger, I come below that, and I feel that bump. So with index and middle finger, I test springing forward. Alrighty? So thank you for letting us film this.
Yes, sir.
And I'll go ahead and have you on your stomach, and I'll spring this spinous process left and right, the first one, with your neck in neutral and in flexion and in extension. And if this is blocked, then I'm just going to gently lean on it and restore normal motion, but I think it's going to be fine. So we can stop filming now. Thanks.